You are welcome to my channel. Thanks for visiting. Please remember to subscribe and share my presentations. I appreciate that. Today is all about a familiar topic, the lower back pain. And that will take us through the pain, the analysis of the pain, and how we can make exact diagnosis as per the cause of the pain. Other possible associated symptoms will also be considered. And then specific diagnosis or definitive diagnosis will be made. We will also go through the red flags like Cauda Equina Syndrome, Ankylosing Spondylitis, Dissecting Abdominal Aortic Aneurysm, Osteoarthritis, Paul's disease, pyelonephritis. In fact, it might even be malignancy or metastasis to the bone. We will all go through the diagnostic process also and the treatment. And we will be concluding with preventive measures. Without further ado, let's go. Lower back pain is a worldwide problem. So nothing is specific or peculiar to a race or region. It is a very common presentation to healthcare centers. If there is no impact, we will not be having this presentation. It has huge impact on the lives of affected people and on the economy. There are signs and symptoms that we will be going into the bit, but I want us to know this before getting there. The pain origin may be within the spine itself, at the lower part there, the lumbar region, lumbosacral region. But sometimes it might be referred pain. From where? In a bit. Our topic is lower back pain. So pain is the main issue of concern here. So it is fair to know everything about pain characteristics. And that will lead us to kindergarten days when we were learning about English alphabets. So we'll need O, P, Q, R, S, T, U, V, W. And then other constitutional symptoms. So the O here will stand for the onset of the pain, the P for progression, whether it's getting worse with time or not, and another P for palliative, that is what relieves you. What can you do to lessen the pain? Then quickly by the side here, I put aggravating factors. I did not put it along this line because A is not going to fit in with the English, alphabet classes here from O, P, Q, right? So A, aggravating factors. What makes it worse? Okay, quality, that is it dull, aching, stabbing, burning, radiation. Do you know the signs? Where has the pain be radiating to? For example, it's from the lower back, radiating to the buttocks, radiating to the thighs, or below the nails. Then severity on the scale of 1 to 10. 1 meaning it's not so much, it's not really bothering me. 5 means it's mild, though I'm feeling it, I'm uncomfortable. While 9 means very, very serious, and 10 means yes, it's the highest pain so far. Then timing. Does it come up early in the morning? What is your understanding as per this pain? What do you think is responsible for it? Is it associated with vomiting? Any associated weakness? When we get the picture of associated weakness, we know we are running into something serious. That is neurological deficit. We'll soon know about Cauda Equina Syndrome in a bit. Other constitutional symptoms, we want to find out. Any fever here, any chills. With that, we will know we are dealing with infection. Then we'll know how to run fast. Still on signs and symptoms, remember when I was going through the characteristics of pain, I mentioned quality, right? Okay, the quality here could be dull, aching, shooting, burning, or stabbing sensation. And also, radiation could be from the back to the boot, thigh, or legs. Aggravating factors means what you do that could make the pain to become worse. Bending, standing, sitting, twisting, walking, or lifting could be the case with lower back pain. What can you do to relieve the pain or improve your situation for better? And that could be resting or laying supine. Then we want to know if there are obvious deformities, no angulation or no change of shape generally. And then we want to also see if there are signs of infection. In fact, we'll be looking out for signs of inflammation, swelling, warmth, pain, or redness. Then history of malignancy or Cauda Equina Syndrome. Here, let me specifically state here that majority of the people that will present with lower back pain, that is about 80 to 90% of them, will present in a typical way. And the typical presentation will be that the pain will be dull and aching, and it will be worsened with movement, will be improved with supine position or lying still. Okay, we should be able to classify the pain based on duration. Acute pain will be any pain from the 1 of first week to 6 weeks, while subacute will be 6 to 12 weeks. Chronic will be greater than 12 weeks. Location and radiation. If the pain is located at the back and radiates to the buttocks or thighs, then it's likely ligamentous strain or muscular strain, and sometimes may be disc-related. If it is located in the back and radiates to below the knees, then it's likely we are dealing with herniated disc at the level of L4 to L5, this is lumbar vertebra, or L5 to S1, impinging on root L5 or S1. That is from the back radiating to below the knees. Still on signs and symptoms, if it is sciatica, or simply put, if the sciatic nerve is the source of this pain, then there will be more pain at the legs compared to the back. So there will be less back pain, but more leg pains. Then we are dealing with sciatic nerve injury, sciatica. Intravenous drug use and immunocompromised state will probably lead to osteomyelitis and epidural abscess. So there's likelihood of constitutional symptoms like fever and chills not being presented at the same time. Someone might present with lower back pain at the same time having eye discharge. If that is the case, we'll be thinking about Richard syndrome, right? Okay, if you want to know more about that, you can click on this very link. Another person might present with fecal incontinence, urinary incontinence, men with impotency, or someone with weakness of the perineal region and weakness of lower limbs. If that is the case, we are dealing with acute emergency, pointing to Cauda Equina Syndrome. For full information on Cauda Equina Syndrome, you can click on this very link. Now, differential diagnosis. So what could this lower back pain be? Might be muscular strain, might be ligamentous strain. These two will not give us so much headache. Might be osteoarthritis. In fact, it could be rheumatoid arthritis. Maybe malignancy, primary or secondary, that would have metastasized the bones, specifically the one that has metastasized the spine. Might be dissecting abdominal aortic aneurysm. That will call for urgent intervention. In a bit, I will go to full details as per this. Might be Cauda Equina Syndrome. I will also delve into further details as per Cauda Equina Syndrome. Might be autoimmune condition, like I've alluded to just a while ago, that might be rheumatoid arthritis. Endometriosis, present with back pain. Fracture of the vertebra, either from trauma or it's just pathological fracture. Maybe as a result of disseminated tuberculosis, now affecting the spine. So TB of the spine, otherwise known as Paul's disease, that could present with back pain. The differential diagnosis will also include nephrolithiasis, that is kidney stone, pyelonephritis, Ritter syndrome, psoriatic arthritis, gout. The differential diagnosis will include posterior lower lobe pneumonia. So it might even be lower respiratory tract infection trouble, maybe as a result of trouble with the pancreas, like pancreatitis or pancreatic cancer. Why that? The pancreas has part of it that is retroperitoneal. Might be renal infarct of Connell's medullary syndrome. In fact, Connell's medullary syndrome will present with very, very serious pain. It might be as a result of osteomyelitis or ankylosing spondylitis. I have a full presentation on ankylosing spondylitis already published. I will drop a link later on. Ankylosing spondylitis is a chronic inflammatory disease of the axial skeleton. Here, something is specific, that is bamboo spine. There may be uveitis, fatigue, and the pain that will be severe at rest. When you, because it is chronic inflammatory disease, right? When you have your rheumatoid factor acid, it will be negative. Might be spinal stenosis. How can we make the definitive diagnosis of that? We'll know in a bit. Maybe causidemia or osteoporotic fracture. Now, let's go through the possible causes of lower back pain together. Somebody will say, oh, but you are showing someone running, right? So running can give us lower back pain. Oh, is it sedentary lifestyle that can give us lower back pain? Do we need exercise? Don't worry. Let's go. Okay, sometimes you might present to your physician, he or she will do everything and find nothing. That's possible because there may be no specific cause in some people. And it might be your shoes that will be responsible for the lower back pain you're having today. Might be as a result of slouching in chairs or while standing. If it's due to activities when we are dealing with muscular or ligamental strain, might be as a result of certain activities like lifting heavy object, sitting for too long, standing for too long, or sudden change in movement and the posture of the back. And of course, sedentary lifestyle. That will match sitting down for too long, right? Other causes of lower back pain will include high body mass index. I've decided to put it this way so that I will not be offending some people, right? High body mass index, but some people will still send questions to me after that. I don't understand what it meant by high body mass index. Simply put, overweight and beyond. Okay, osteoarthritis, rheumatoid arthritis in autoimmune condition, right? Osteoporosis, elderly people, particularly postmenopausal women. Smoking. Smoking here will be a problem and lead to lower back pain when there's persistent coughing that may lead to disc herniation. It's not pretty common, but it's a possibility. Another trouble associated with smoking that can lead to lower back pain will be when smoking causes ischemia. That ischemia can lead to osteoporosis. And remember, osteoporosis on its own can be responsible. Other causes will include pregnancy. It's a beautiful problem, right? You are happy you're pregnant, but you may have lower back pain. In fact, they have lumbar lordosis in pregnancy. Endometriosis, classical presentation will include lower back pain. Hormonal changes, particularly in women. And of course, childbirth. You need to see women during labor. In fact, I will encourage all partners who will like to see their wife during delivery to be there. They will appreciate more. Other causes will be problems associated with disc. And you could see two different spellings, one for Europe, one for North America. So it's either we are dealing with disc degeneration, herniation, disc prolapse, stenosis of the spine, radiculopathy, leading to nerve entrapment and then impingement. Another cause will be spinal stenosis. Here, this will be leading to bilateral sciatic pain. The pain will be aggravated when there's extension of the back or when the affected person is standing or walking. Then there will be alleviation or improvement with forward flexion. For example, when you are in the mall or you are in a grocery store or anywhere and you are pushing the cart or trolley. One is in North America, the other one is Europe. In the case of herniated disc, it will be aggravated or it will be made worse by coughing, sitting, and vasovagal maneuver. The pain will improve when the affected person lies supine or supination position. When the cause is tumor or infection, then the affected person will have pain that will be occurring at night. The pain is likely going to wake him or her up at the middle of the night. And one other feature here is that it will be unrelenting. You lie supine, you do everything that will relieve other pains like the one caused by muscular strain or ligamental strain. That won't work here until you have dealt with infection or the tumor is being addressed. Now, when the problem is degenerative spondylolisthesis, we'll be thinking about women, particularly postmenopausal women with low level of estrogen. Now, let me talk more about this. Since we are all familiar with the fact that spondylolisthesis is all about slipping of one vertebra over the other, here we'll be dealing with postmenopausal women with low level of estrogen and then having vertebral discs that will be degraded. The ligaments will become loosened and then there will be spinal instability. With or without spinal osteoarthritis, the spinal instability will lead to vertebral slipping over the other. The one above will slip over the one below, then leading to back pain. And the back pain here will be radiating to the legs. And that will become worsened or aggravated while walking. And sometimes it could lead to neurogenic claudication. So if the spinal cord is also compromised. There could be secondary metastasis to the spine, and that could be from primary cancer in the breast, lungs, thyroid, prostate, kidneys, or multiple myeloma, lymphoma, or from sarcoma. Now, the red flags. Normally, a larger percentage of people with lower back pain will have no red flag. And the treatment will be very, very mild, sometimes none. And there will be no long-term complications or horrible outcomes. But few people will not be that lucky. They can present with lower back pain, but the cause or causes might be something more serious. In fact, could be something that will require emergency intervention. The intervention might even go beyond orthopedic department, can even involve cardiothoracic unit. Sit back, let's go through red flags. What we can pick during the history and physical examination, including investigations, and we must act fast. As a matter of fact, we'll be looking for red flags when someone presents with lower back pain. And here, my number one diagnosis that will make me run quickly will be Cauda Equina Syndrome. Here, I have full presentation on Cauda Equina Syndrome. The Cauda Equina means horse tail. Here, spinal cord passes through the vertebral column and it covers the lumbar and sacral nerve roots. The Cauda Equina is the bundle of nerves at the end of the spinal cord. At the lowermost part in the sacral region, that is where you're going to find the Cauda Equina. Cauda Equina, once again, means horse tail. Now, it is a surgical emergency, all at the perineum and external genitalia, including the anus. There will be saddle anesthesia, meaning the area in contact with a saddle while you are riding a horse. Then there will be sensation of pins and needles at the perineum, including numbness and loss of pain. The lower back pain in Cauda Equina Syndrome will be very severe. There will be sciatica, paraplegia, fecal incontinence, urinary incontinence, erectile dysfunction in males, decrease or absent reflexes. The individual will be falling frequently, apprehension and depression. The sciatic nerve is L4, L5, S1 to S4. The Cauda Equina is L1 to L5 and also S1 to S5. The causes of Cauda Equina Syndrome will include trauma, like road traffic accident, compression fracture, ballistic trauma, or iatrogenic, particularly from lumbar puncture. So on causes of Cauda Equina Syndrome, It might be lumbar spinal stenosis, ankylosing spondylitis. I've left a link earlier. I'm going to leave again. Might be Paget disease, rheumatoid arthritis, osteoarthritis, TB of the spine or pulse disease, obesity, heavy lifting or pregnancy. The history here, that is in Cauda Equina Syndrome, will be that there's history of pulmonary tuberculosis that has now disseminated, leading to pulse disease, or history of trauma, pregnancy, or autoimmune conditions, and so on. Then there will be physical examination, and then magnetic resonance imaging will be the best diagnostic procedure. CT and ultrasound to check the bladder because there will be urinary incontinence. How do we treat Cauda Equina Syndrome? The definitive treatment is emergency surgical intervention for decompression, and that could be laminectomy. But before the consult will get to the surgeon and it will come, you can give analgesics. If there is infection, you give antibiotics, and if there is an abscess, then there must be incision and drainage. When tumor is picked, the tumor must be taken out, excision of the same. In the case of inflammatory process that is identified, we give steroid. Still on treatment, we will later advise the individual to embark on lifestyle changes, particularly if the body mass index is pretty high. Then Kegel exercise. Early intervention will be pretty helpful in preventing long-term damage. The key here is early detection and immediate intervention. Another red flag will be ankylosing spondylitis. Here, there's a full presentation on ankylosing spondylitis. Please click on this very link to lead you to full info on ankylosing spondylitis. But I'll just briefly mention something about it here, that it is a chronic inflammatory disease of the axial skeleton, and you are going to pick bamboo spine. But ankylosing spondylitis is not limited to the spine as a problem. It is going to affect the eyes, leading to uveitis, fatigue, generally. The pain here will be severe at rest, but at the same time, it's going to destroy the aorta, acute aortitis. So ankylosing spondylitis is a very serious problem that must be dealt with immediately. Another red flag will be dissecting abdominal aortic aneurysm. Well, my thinking is that this should not even be under lower back pain, red flag. And someone will fight me, for that, right? Well, that's fine. But do you know why I've said that? We will pick problem in the chest region radiating to the back. And it's going to be sudden. The pain will be so sharp, tearing and stabbing. And of course, there will be dizziness, shortness of breath, and when we take the blood pressure, there will be hypotension. So it is good that it is under, red flags for lower back pain, but the presentation will be so classical that you can't miss it. This is more than lower back pain. Another red flag will be unexplained weight loss. Let me explain the unexplained weight loss. Here, you've not been dieting. You've not had surgery. You are not taking pill to reduce the weight. You just, found out maybe through regular weighing and everything, or your pants or shoes or wristwatch that you are losing weight, but you have lower back pain. That may be pointing to something serious. It's probably because you are having cancer. So better see the physician and let them do everything right now. And this could also occur in people with tuberculosis that has disseminated and has affected the spine. So TB of the spine or pulse disease could also give us this picture. Now, red flags might be that the pain is very severe. Remember, I said the typical presentation would be dull, aching pain, right? That is aggravated with movement and alleviated when you rest or put yourself in supine position. But when the pain is very severe and it is localized, then something is serious here. If the pain is so severe or unrelenting to the point that it's affecting your activities of daily living, then we know it's no longer a joke. Another problem that will give us concern is if it is not responding to interventions, then there's trouble. Or it is lasting more than 6 weeks, or the pain is waking you up at night, then we have to dig deeper to get the cause. When there is lower back pain with constitutional symptoms, then we know we are dealing with something serious, like fever, chills, and night sweats. Or there's lower back pain, but this individual is immunocompromised. Or this person is using intravenous drug users, or this person is on steroid for a very long time, or there is history of trauma with possible fracture. Another red flag would be that the pain is radiating to below the knees, or the pain increases with coughing. That is pointing to herniated disc, or there are neurological deficits. If that is the case, we are likely dealing with Cauda Equina Syndrome because it will be rapidly progressive. So rapidly progressive neurological deficit is pointing to Cauda Equina Syndrome. And remember, that is an acute emergency. Another red flag will be the age at presentation. Anyone less than 18 will give us a big concern. The reason is the common age for benign cases will be 30 to 40, although benign cases can occur at any age. Now, someone less than 18 will be thinking of spondylolisthesis at L5 in early adolescence, which can progress to spondylolisthesis at L5, S1 slippage. But spondylolisthesis can occur at any age. So when we see somebody less than 18, we'll be thinking of spondylolisthesis. Another red flag under the age would be someone older than 50. Here we'll be thinking of something as serious as dissecting abdominal aortic aneurysm. Here, consult will be sent to cardiothoracic surgeon immediately. Imagine, from lower back pain presentation to cardiothoracic surgery. Spinal stenosis, secondary to degenerative disease, will also be the probability at age greater than 50. Malignancy could be the issue here also at more than 50. Vertebral compression fracture is another possibility here. Then spondylolisthesis at L4, L5 slippage in female adults due to degenerative disease might be the issue at greater than 50. Remember, I've said something about that earlier, but I won't mind because you need to get the facts right. So someone older than 50, why is that a red flag for us? It is a red flag if it's a woman, particularly postmenopausal women with decreased estrogen. And why that? That will lead to vertebral disc degradation. And that will lead to ligaments becoming loosened with spinal instability. There may be or not other associated problems, but that on its own can lead to vertebral slipping from the upper one over the lower one, like L4 slipping over the L5. And of course, we know what that will lead to, right? Back pain that will relate to the legs. Risk factors here will be age, mostly 30 to 40. When it's less than 18, we can't be comfortable. When it's greater than 50, we will not be comfortable. It's not that we are happy that someone 30 to 40 is having lower back pain, but that is the age bracket that we will likely pick lower back pain. Sedentary lifestyle is not going to help lower back pain, okay? That will likely give you lower back pain. If your weight is high, if you have high body mass index, you may likely have lower back pain. The presence of cancer, or you have immunocompromised state, or you're on avid drug, you use intravenous drug, or there's arthritis in you, probably because you have autoimmune conditions, or you have depression or anxiety somewhere, or you are lifting heavy equipment, but with poor lifting technique, you are likely going to have lower back pain. If you are smoking, then you are likely going to have lower back pain. And someone is asking, how can smoking lead to lower back pain? I've stated this before, but I'm going to state it again, that if you are smoking and you are coughing frequently, that frequent coughing can lead to herniated disc. And also smoking can lead to ischemia, and that can eventually lead to osteoporosis. Now, the diagnosis. It's not that it's difficult to say, okay, someone is having pain, and then we just give painkiller. But we need to get down to the root cause. Remember, we've gone through possible causes, we've gone through symptoms, we've gone through red flags, right? How can we make definitive diagnosis of the specific cause of this lower back pain? Let's go. We'll take history. The history will include everything that I've said before now. The history of trauma, the pain, the radiation, the characteristics, the severity, whether it wakes you up at night or not, affecting your daily activities or not, related to fever, chills or not, is it that you're pregnant? Can we actually see the protruding, abdomen sign of pregnancy? So many things will be included, including past medical history, maybe road traffic accident in the past. Is this Cauda Equina Syndrome? Any fecal incontinence, urinary incontinence? We take history along that path. Like dissecting abdominal aortic aneurysm, from history we'll know we're dealing with something scary. Dizziness, shortness of breath. The nurse will take the vital signs and say, oh, dog, there is severe hypotension here. With history of sharp, sudden pain, then we know this is not funny. And of course, we do vital signs, right? That's how we know there's a potential. That's how we know there's fever. And we may be thinking of osteomyelitis when there is fever and so on, like that. And of course, history of weight loss also will be pointing to something serious, okay? Then we have physical examination done. I don't want to say much about that because I will go through physical examination very soon. We'll get to lab. What are we going to do there? I'll go through that also. Radiological investigations, I will go into that in a bit also. So, okay, we'll have physical examination that will include general appearance, neurological examination, the examination of the abdomen. Someone is asking, what's the business with abdomen here? We've just gone through it. We may be having red flags pointing to dissecting abdominal aortic aneurysm. So one thing is different though. When it comes to examination of the abdomen, we will inspect and move straight to auscultation before doing the rest, percussion and palpation. So we will be going through inspection, including gait. Tell the patient to walk to the door, walk back. Then any examination orthopedics we have to do gait. So we will inspect for swelling, erythema, atrophy, deformity, scars. Don't worry, I'll still get into that. Palpation for temperature, tenderness, crepitus, then effusion and range of motion. Then we'll have motor and sensory done. And so it depends on exactly what we want, but in this case, we from hip down to the feet. And a sensory as test will also be done. Also, we have reflexes, deep tendon reflexes. Don't worry, I'll go into that. Then we will have pulse taking, then we have special tests. Don't worry, I'll go into all special tests that'll be done. Now, the general appearance. Here, we will check for any obvious scar that will point to whether there's trauma or past surgery here that is responsible for this lower back pain today. We'll also check for any swelling. It might be cancer of the bone or abscess that's formed there that's causing the pain right now or anything. Then we'll check for any symmetry or asymmetry. Okay, then we'll move to the swelling could be mass in any way, so it could be the same. Then muscular atrophy, and then any alignment or any obvious deformity. We'll check for any erythema. And are there rashes? Of course, do we see bruises here? We want to know. That will be pointing to trauma, right? And then signs of inflammation. Do we have swelling, warmth, redness, and tenderness, or swelling, warmth, erythema, and pain? So it depends on, because I decided to bring it out these two ways because some will be familiar with one, another will be familiar with the other. And gait, we want to know, untidy gait or not, whether the person is working with pain or not. So that will give us clue. Okay. A neurological investigation. And this case will settle down for lower limbs and hip. So we'll do inspection, the tone, the power, and deep tendon reflexes. When it comes to the inspection, we want to know if there are tics, tremor, chorea, or fasciculation. Then the tone, we want to know, passive range of motion and active range of motion. We want to see whether there's hypotonia or hypertonia. Then we check for the power. The power here, we want to grade it. 0 means none. 1 is flicker. 2 is without gravity. 3 with gravity. 4 with some resistance, and 5 with full resistance. Then we are going to have deep tendon reflexes. Patella is L2, L3, L4, while ankle will be S1, S2. And then hip flexion is L2, knee extension is L3, knee flexion is L4, ankle dorsiflexion is L5, ankle plantar flexion is S1. The reason is there will be a time when we will need this dorsiflexion and plantar flexion to distinguish certain features in a bit. Now, special test. Straight leg raising test. Some call it this, another one will call it this. So, everybody's familiar with the first one. Here, if it is positive, don't worry, very soon I'll start making physical examination presentations. So I'll do all this. So if straight leg grazing test is positive, that means that there is sciatica or radicular pain, and it's going to be down the affected leg, radiating below the nail. That will be sensitive for L4 to L5 or L5 to S1 herniated disc. Radicular pain, however, will be worsened by ankle dorsiflexion. Remember, we've just gone through it, right? That will be L5. While radicular pain will improve with ankle plantar flexion. That will be S1. Another special test will be positive cross straight leg raise. In this case, we are going to examine the leg that is not having pain. So that is the leg that will be raised. When it is raised, we expect pain to be felt at the opposite side, meaning at the affected leg. That will confirm radicular pain with nerve root compression secondary to disc herniation. That's a positive cross straight leg raise. The non-affected leg is raised. Pain will be felt at the affected leg. Radicular pain with nerve root compression. Another special test will be modified scuba test, pointing to Ankylosing Spondylitis. There's a full presentation on Ankylosing Spondylitis already here. If you want to know more, you can click on this very link. Babinski test could also be done, and it will be appropriate to have digital rectal examination. Why that? We've been talking about Cauda Equina Syndrome. So digital rectal examination will give a clue that there's laxity, or weakness of the rectal tone. Now we're to the lab. Complete blood counts. We want to know if there's anemia or signs of infection. ESRC, reactive protein, pointing to inflammatory process that is ongoing here. Pancreatic enzymes, we'll be talking about pancreatitis and pancreatic cancer, right? Renal function test, we thought of possibility of pyelonephritis the other time, and particularly in someone having urinary incontinence, although it's pointing to Cauda Equina Syndrome, but when there's urinary incontinence, have urine analysis and microscopic culture and sensitivity done. Although this will help also when it comes to pyelonephritis. And then rheumatoid factor, antinuclear antibody, pointing to autoimmune condition. We want to rule that out. Remember, we said, rheumatoid arthritis could be responsible. Glucose, yeah, we've been talking about metabolic derangement, we've been talking about immune compromised state. When diabetes is in the system for a long time, it can lead to immune compromised state. Beta-hydroxycholic gonadotrophin, of course, we will expect gravid uterus that has already grown past first trimester, second trimester, because it depends on individuals. We cannot say that the gravid uterus the age or gestational age must have reached the third trimester before you see lumbar lordosis and then have lower back pain. No, you will see some women at second trimester, everything is already bulging, and you will see some at third trimester, hardly will you even know they're pregnant. So if we want to take that physical judgment to say, okay, at third trimester, there should be lumbar lordosis, and then there should be lower back pain, we might be wrong. But let us just be sure the woman is not pregnant. So beta-hydroxycholic gonadotrophin will give us. And then if we are concerned about tuberculosis, interferon gamma release assay will be helpful. And then alcohol acid fires bacilli, particularly if the person is also coughing, right? The person coughing, is he or she smoking? Then you match that, of course. It's not going to cost too much, but healthcare delivery is not the same all over the world. Some will have to pay through their, I don't know, through the nose, through anything to be able to pay for any of these tests. So we should, let me say here before leaving this page that it's not that all these investigations are compulsory per se. It depends on the degree of suspicion of what we think or what we imagine could be responsible. Many times we will do nothing. I'm telling you, many times we will do none of these investigations. Many times when it comes to lower back pain. But when we're concerned about red flag and we want to make specific diagnosis or definitive diagnosis, then we embark on some of this. At no time are we going to do all this together. I don't think so. No. Because I don't expect one person to have how many diagnoses? Man, no. Arthrogenesis could be done when we are concerned about infection and gout. So we have the sample for MCS, for cells, and monosodium urate crystals. Now, radiological investigation. Like I've said earlier, all these investigations, sometimes in majority of people that present with lower back pain, nothing will be required. But some, when we need to get down to the bottom, we will have to do some of these investigations. At no time are we likely going to do all. So it might be ultrasound when we are concerned about abdominal aortic aneurysm or what's going on in the abdomen. CT scan will also help with that. Then when there is urinary continence, if we are unable to rule out Cauda Equina Syndrome immediately, you might have ultrasound done, and then X-ray of the spine, X-ray of the abdomen, abdominal pelvic X-ray, depending on what we're trying to arrive at. MRI is the best. It's the best here because MRI can help with infection, can help with compression fracture, can help with many things. CT will be better when it comes to bone delineation, right? But MRI is the best radiological investigation. Now, some went back on bone scan, but Even if you can't do anything, if you do ultrasound, if you are thinking of anything in the bladder, anything in the abdomen, and then you have MRI done of the spine, we should be fine. No, even regular X-ray can help, but may not get down to the root of the problem. Now, the treatment. Well, don't let me say I know, but let me say my assumption is that many people will click on this very presentation because they just want to know how to treat lower back pain that they are having, or their friends are having, or their parents are having, as the case may be. So now we've reached where many people will want us to go. The treatment of lower back pain. Is it all the time we need pills? I don't think so. It's not all the time that I will prescribe pills for someone having lower back pain. Remember everything we've gone through before we reach this stage. Now, we must first of all determine if we are dealing with red flags or not. So we might even need referral right now. We may not even do anything right now because it is more serious than what could be done at the clinic. Or it's more serious than what could be done by determined by the level of my training or not. Okay? So sometimes we'll refer immediately. And let me end that by saying, for example, the diagnosis is dissecting abdominal aortic aneurysm. What am I waiting for? Cardiothoracic unit. Immediate classification into benign or severe is pretty important. So we cannot just be toiling with human lives, making a guess. No, we must make that determination quickly that this is benign. Okay, we will do nothing, or we do just a little stuff, or this is severe. Another person must take over right now. That determination must be made immediately. Majority will not require much. In fact, some will require no treatment, zero. So majority will not require much intervention, or at least they will require just minimal intervention. And then they will have the lower back pain resolved in 2 to 6 weeks. Okay, if we have made up our mind that, okay, this is what we can handle, this will need no referral, this will need no other department to handle it, let's start with non-pharmacological intervention. First thing first, education. The patient should be advised against making the injury to become worse. Okay, so another issue will be cooperation between the doctor or the therapist and the affected person. That will be vital. If there is depression or anxiety, that should be addressed. We should ask history surrounding depression and anxiety. If not, there's no pill you give. Patient is coming back. We should let whoever is having lower back pain know that doctor shopping, looking for opiate, is not the way out. As a matter of fact, we should state the consequences of opioid abuse. That may, but not limited to, death. Non-pharmacological intervention can also include the following if it is benign. Benign and not interrupting normal daily activities of the affected person. If that is the case, we can just tell the individual, continue your normal daily activities. Yeah, just continue. Be doing what you are doing, continue to enjoy your life. No more exercise, right? And advise that Don't ask for sick leave. No. Don't stop working. Continue to go to work. But we will make that determination when we know this is extremely benign, not interrupting sleep, not interrupting daily activities. So if that is the case, just continue. Don't go home and rest. Don't go and sleep on bed for 2 days. No. But if it's a bit more than the above here, then we can ask for 2 days of bed rest. We'll then issue sick leave. Please let this staff of yours rest for 2 days. That's my determination. If it is greater than the number one here, okay? Assurance of early recovery. But the affected person may seek for longer bed rest. I will let you know. That will be detrimental. Still on non-pharmacological intervention, please continue active exercise. Remember, sedentary lifestyle is a risk factor. Then you can apply ice. If you are used to heat application will help. So you choose either ice application or heat application. Laser or massage. But some might not be able to afford this one. So if you have coverage for them, good. Wear good shoes. In fact, part of the physical examination should have involved checking the shoes, right? The soles of the shoes also. Look for the way to share the weight. Have a good diet. Stop smoking. I've explained how smoking could lead to lower back pain. Let me say it for the last time. When you are smoking, and you have been smoking for a long time, and you are coughing repeatedly, that is not caused by cancer, not caused by tuberculosis or anything else, that frequent coughing can lead to herniated disc. And the smoking also can lead to ischemia that will eventually lead to osteoporosis. If there are associated disease or diseases and such has been identified, that must be treated also, like depression, anxiety, diabetes mellitus. When there's trauma with fracture, let the fracture be fixed quickly. Nephrolithiasis should be treated appropriately. Dissecting aortic aneurysm, do I even need to leave this here? That will be referred immediately and be handled immediately. Pancreatitis to the appropriate unit, and pancreatic carcinoma to oncologists. Now, pharmacological intervention. We will start with the lower Coda, okay? Topical analgesics, Votarin, and so on. Acetaminophen, Tylenol, paracetamol, whatever you call it in your region. Non-steroidal anti-inflammatory drugs. Here, I will not rush through this. Here, it could be ibuprofen, could be naproxen, but those ones will cause gastrointestinal tract ulceration, okay? In that case, you add misoprostol cytotec is the better option when it comes to non-steroidal anti-inflammatory drugs related peptic ulcer. Misoprostol is better. But if proton pump inhibitors will be what is available in your region, like omeprazole, you can add. So either ways, either cytotec, misoprostol, or omeprazole proton pump inhibitors, in addition to your ibuprofen or naproxen, that will help the patient. But if you want to avoid gastrointestinal tract, you can use electroscopy. That is good because it will not give you gastrointestinal tract ulceration much, but you'll be dealing with another complication like myocardial ischemia. Okay, then you can go leave this stage to muscle relaxant. Narcotics, could see I put a lot of stars here. We have to be careful because of the possibility of addiction, right? So we're not going to go for the highest level like morphine, hydromorphone. No, oxycodone and hydrocodone will be fine. Then, if we're not winning, we can have antidepressant on top of that, like tricyclic antidepressant, amitriptyline can be helpful, and then duloxetine, that is in bottle, can be helpful. But remember the anticholinergic side effects of tricyclic antidepressants. That must be fully explained. Some went back on steroid injection. Then physiotherapy or physical therapy is the same. Just one is zero, one is North America. So, and then you refer to spine surgical unit for intervention by spine surgeon. In that order. Surgery may involve cortisone injections, radiofrequency neurotomy, or implanted nerve stimulators. Specific treatment could be embarked upon under specific diagnosis. For example, acute radiculopathy. If that is the case, we can have the individual advised that you have to decrease certain activities with the goal of decreasing exacerbation. Okay? Then instead of no bed rest, continue activities, continue to go to work, no. We will actually give sick leave of 3 days, rest at home for 3 days, bed rest for 3 days, not 2 days. Then use non-steroidal anti-inflammatory drugs, either celecoxib, naproxen, ibuprofen, then protect the gastrointestinal tract with proton pump inhibitors or misoprostol. Then, if you're not winning, you can add narcotics, but we're not going for hydromorphone now. We'll just settle at the level of oxycodone and so on. Then, lumbar traction, and then transcutaneous electrical nerve stimulation. In case of osteoporotic compression fractures, or even any other causes of lower back pain, you can embark on the use of causes. So, like lumbar to sacral orthosis, some will put it as lumbosacral orthosis. You can embark on that, on braces, bar supports, and abdominal binders. Now, you've done everything so far, and you need surgery. Well, let's see where and when surgery will be required. If it is Cauda Equina Syndrome, that is an acute emergency. Surgical decompression, laminectomy, will be required right now. In the case of dissecting abdominal aortic aneurysm, cardiothoracic unit immediately. In this herniation or spinal stenosis, we revert to spine surgery. Okay, prevention. Prevention, they say, is cheaper than cure. That is, if the condition is even curable at all. That is what I have said repeatedly on my channel. So let's do everything to prevent lower back pain. For example, don't twist your back suddenly at any time, either while exercising, lifting a heavy object, or even while sitting. Don't twist your back suddenly. Let there be training on correct lifting technique, because some will get lower back pain from lifting heavy objects. Quit smoking. I will not tell you for the fourth or fifth time why that will lead to lower back pain again. If you want to know, pause, rewind. I've explained that 3-4 times before now. Let's share that weight. Let's do it. Increase exertion, meaning no sedentary lifestyle anymore, please. Get out of the couch, walk the dog, or participate in exertion, exercise around. No need of special shoes or furniture or back support or stress management. Don't waste your money on all this to be able to get out of lower back pain. No, you don't need that. Just embark on this full stuff and many other things that can help you, but you don't need special shoes anywhere, special furniture anywhere, or stress management. No. In conclusion, no one should die from low back pain if they will present on time, and then definitive diagnosis could be made on time. So, if anyone is presenting on time and serious conditions are ruled out quickly, meaning red flags are scanned, searched for, and not found, then we are fine. But if red flags are picked, like the case is here, dissecting abdominal aortic aneurysm, or Cauda Equina Syndrome, or Ankylosing Spondylitis, or pyelonephritis, osteomyelitis, malignancy that is not known to the affected person, or any other serious condition or condition like even pulse disease, when the patient doesn't even know he or she has TB or has not been taking correct treatment as per tuberculosis treatment. If we are able to intervene in the appropriate manner like that, then nobody will be killed by lower back pain. And when we are talking about the treatment, we should start with non-pharmacological interventions. And when we want to begin the pharmacological interventions, we should start from the lowermost parts, least troublesome, and then go up from there. Like topical analgesics should be the beginning. If we are not winning, we can then get acetaminophen over the counter. Then non-steroidal anti-inflammatory drugs, ibuprofen or naproxen. You may go for another. Then you can add misoprostol or omeprazole to that to protect the gastrointestinal line. And then you go a step further to get muscle relaxant, but we must discuss the possible side effects. If you are not winning, then you can grab narcotics. But we are not going for hydromorphone right now. You can settle down for oxycodone or a member of that group, hydrocodone. Then we go for steroids injection, or we move further to physiotherapy or physical therapy. Then we can go for antidepressant, duloxetine or amitriptyline, and then referral to spinal surgery. So with that, I come to the end of this presentation. as per low back pain. It should not be killing anyone. Thanks for listening. Please remember to subscribe to my channel. Remember to share this presentation on your platform. Let everyone know that lower back pain should not be killing anyone. Thank you.